Friends, today we are going to discuss regarding the syndromic approach to infections. So, in today's era, infectious diseases are becoming challenging to treat because of the antimicrobial resistance, and it's important that for early cure and prevention of emergence of resistance, we start the appropriate treatment at the earliest, both in the OPD as well as in the hospitalized patients. And for this, we must begin with the site of infection as well as the syndrome we must identify with which the patient is presenting. Now, each syndrome can have several possible pathogens, especially in our immunocompromised patients. The principle of parsimony that a particular syndrome is caused by only a single pathogen, this may not exist. In immunocompromised patient, there can be multiple pathogens possible as well. So that is why to identify the exact etiology, which is important to start the appropriate treatment or to continue the appropriate treatment, we must adapt to newer technologies, the next gen solutions in our clinical practice. So in today's era, a syndromic approach to infectious diseases is very important, and I was lucky to author this chapter along with my mentor, Dr. Rajiv Soman sir. And our approach as clinicians is to combine clues from a detailed history, which is the skill of an infectious diseases specialist, with a good clinical examination and correlating it with the labs for establishing the likely etiology of the infectious diseases. Now, for arriving at the diagnosis of infection, traditionally we have been, there are several approaches which can be adapted, which includes the microscopy, culture and sensitivity, serology, antigen detection, as well as the molecular assays. And all of these are very important and they have their niche areas. But yes, the more rapid we identify the etiology, the better we can be, the more confident we can be in continuing of the antibiotic or the antimicrobial therapy. So rapid diagnosis is essential for the right treatment at the earliest. For this, the molecular assays are the new powerful diagnostic tools. And in fact, they have changed the way we treat tuberculosis by the early diagnosis of MTB with the help of expert MTB PCR, which is especially the gene expert. Also, the molecular assays, the PCR assays, are helpful in identification of difficult to grow pathogens like the viruses, chlamydia, especially in the STI, the anaerobes, or even the fastidious, as well as help in detecting the polymicrobial infections, which are difficult to diagnose only on the basis of cultures. They are also useful if there is a prior antibiotic exposure. Besides identifying the etiology of the pathogen, it also helps us in identifying the mechanism of resistance. For example, in case of MTB, we have rifampicin detected or not detected, which helps us in identifying the treatment plan. And of course, for Enterobacteriaceae, whether it's NDM or OXA48, so hence the choice of antibiotics can be modified. Again, they're also useful for the monitoring of treatment in case of viruses like the hepatitis B as well as the HIV with the help of monitoring of the viral load assays. Now, I will be discussing a few syndromes here with the help of cases. This is a 75-year-old gentleman who had diabetes, who had hypertension, and he had received permanent pacemaker implantation. And currently, for sarcoidosis, he was on steroids 40 milligrams once daily. Now, in 2018, he was admitted with altered sensorium, which was thought to be probably because of urinary tract infection on the basis of this E. coli report, which was from the urine, and this was a E. coli which was susceptible to the carbapenems. It was ESBL with resistance to third generation cephalosporins, but sensitivity to the BL-BLI combinations. He had leukocytosis as well as the serology which was performed was also positive. So there was also a suspicion of rickettsiosis. Since there was altered sensorium, he underwent imaging and that revealed that there was this meningoencephalitis along with a ring enhancing lesion. Now, with this ring enhancing lesion, there was also a suspicion of tuberculosis in the mind of the clinicians. Now, when the CSF was performed, that showed that there is a CSF pleocytosis, which is predominantly lymphocytic with elevated in the proteins and hypoglycoria. The CRP was elevated, but not too much. It was elevated to around 30. Now, based on this patient was initiated on ceftriaxone, doxy, anti-TB drugs, Dexa, and an ID reference was sought. So when the ID reference was sought, for us, the question was, what is the patient suffering? Whether it is a bacterial infection, whether it's tuberculosis, or it is some other etiology. So as the patient had this ring enhancing lesion and the patient was already started on the anti-TB drugs, we also calculated the modified Thwaites criteria, which is based on the age, duration of illness, peripheral WBC count, CSF WBC, and the neutrophils. Now, this was a value of 6. Now, this criteria helps us in identification of or differentiation of TB, meningitis versus bacterial infection. A score of 4 or less is associated with TBM and here the score was 6, so it was not favoring TB meningitis and it has a very good sensitivity to it. At the same time, this patient was not having any pneumonia either. Now we know that 25% of the TBM patients may have associated lung involvement, so the possibility of TB was less. Now, at this point, besides, of course, the clinical history, is there any investigation which can help in the rapid diagnosis and which one it will be? So whether it's the blood culture, CSF culture, CSF gene expert in parasequencing or none of the above. So the correct answer is none of the above. And why? Because the blood cultures can help us in the identification of pathogens like Streptococcus pneumoniae, which can cause meningoencephalitis. But in case of strep pneumoniae, it is a fulminant meningoencephalitis. Besides, there will not be any ring enhancing lesion. So that is less likely. Of course, we must send this, but this is not going to give us the clue towards the etiology. Besides, blood cultures or CSF cultures are going to take time. It will be at least 2 to 3 days later. CSF gene expert and biosequencing should also be performed. It can help us in the in ruling out TB, but from our clinical history and calculation of the modified Thwaites criteria, which is a score which has been validated even by leading institutes, it is not favoring TB meningitis. So what is likely in this patient? So if we look at this, the syndromic approach is important, and as clinicians, we must try and identify the likely pathogen in the syndrome. So, we know that Streptococcus pneumoniae is the most common pathogen across ages. And also, it will be considered if there is a CSF breach, neurosurgery, CSF rhinorrhea, basilar skull fractures. But the presentation in this patient is different. It is not a um, fulminant onset. Besides, there is a ring enhancing lesion, and also there is a lymphocytic predominance without a prior antibiotic exposure. That again goes up besides this, the CRP is just 30. In strep pneumoniae, there is intense inflammation and the CRP will be very high. The other possible pathogen is Listeria monocytogenes, which occurs in elderly patients more than 50 years and immunocompromised patients. Now, this patient is elderly. Besides, this patient is also on steroids. Staph aureus should also be considered. Both MSSA and MRSA are possible, especially if the patient has got some skin abscesses, a line-related infection, sepsis-like syndrome, bacteremia, some penetrating trauma or CSF shunt infection. A patient presenting with acute meningoencephalitis, acute febrile illness with rash, eschar, rickettsiosis, meningococci should be a possibility. CSF shunt, penetrating trauma, infections with Coagulase negative Staphylococcus, Staph aureus, gram-negative pathogens should be considered. G and B, E. coli, Klebsiella pneumoniae, Acinetobacter, and as well as even Enterococcus are a consideration post neurosurgery following some penetrating trauma and in case of CSF shunt. So there is a list of pathogens. However, even clinically, there can be certain clues and risk factors which can help us in predicting that these could be the likely pathogens. Now, how do we confirm it? Because confirmation is very important. So there is a battery of tests which needs to be performed for arriving at the diagnosis of meningoencephalitis and the likely etiology, and this includes the radiology. We must do CSF, which has to be sent for a biochemistry, microbiology, and hematology. Along with that, a CSF lactate and a CSF PCT can also be considered. Microscopy is also essential, which should be at least 1 ml should be sent for the gram stain, and even gram stain positivity can give us a clue towards the likely bacteria, but this has limited sensitivity because many times patient is already receiving the antibiotics. Similarly, CSF should be sent for the cultures, and the cultures should be at least 5 ml in the blood culture bottles. The turnaround time is a lot, it's 2 to 3 days, and sometimes it may be kept for the prolonged incubation. And that is why, since the cultures and there is limited sensitivity of the other methods, the molecular assays have found a niche area in the diagnosis of community-acquired meningoencephalitis. And we have this multiplex PCR, which is the Filmary Meningitis Encephalitis panel, which detects the 14 common pathogens which are responsible for the community-acquired infection. Remember that this pathogen identifies the bacteria, which includes Strep pneumoniae, Neisseria meningitis, Strep ecclesiae, H. influenza, Listeria monocytogenes, and E. coli. Viruses including the enterovirus HSV1, HSV2, HSV6, CMV, VZV, as well as the paracovirus, and fungus, which is Cryptococcus neoformans. However, it does not detect MTB, which is a very common cause of meningoencephalitis in our country. It lacks detection for rickettsiosis, bacteria like Acinetobacter, Klebsiella pneumoniae, Enterobacter, which are also important causes of nosocomial meningitis, Enterococcus, Coagulase negative Staphylococcus, viruses like Japanese encephalitis, KFT, Nipah, and there is also a caution for Cryptococcus. Although the panel has Cryptococcus neoformans, however, it definitely calls for caution because even in my experience, there have been 3 cases of CSF culture positive cases and CSF crack positive cases where the multiplex PCR was negative. So for community-acquired bacterial meningitis as well as for the viruses, it's a very good test. However, we need to also keep in mind the limitations of the CSF multiplex PCR. So in this patient, when the CSF was performed, the same day we had the etiology detected and it was Listeria monocytogenes. So this was detected in the CSF. There was no Streptococcus pneumoniae which was isolated, and of course no virus etiology was detected either. Hence the diagnosis was clear, and the clinical impact of this positive CSF multiplex PCR was that antibiotics, which included ceftriaxone, and anti-TB drugs, doxycycline, dexamethasone, all were discontinued because there is an evidence for the diagnosis. The wheal Felix was also now a non-specific test. Again, as the urine culture was positive and there was an initial suspicion of urinary tract infection, and there was a consideration that probably meropenem should be started. So meropenem was not started in this patient with a positive urine culture. This was an asymptomatic bacteriuria. And this patient was treated with basic antibiotics, which included ampicillin with gentamicin, which was initiated in view of the positive multiplex PCR. And also it gives confidence to the clinician to switch or discontinue all the antibiotics and only continue ampigenta. Now, 2 days later, the CSF culture did grow the gram-positive bacilli, which was initially being considered as a contaminant because it's a GPB. But since we knew that already the CSF multiplex PCR has detected the Listeria monocytogenes, we requested our microbiologist to further incubate, and then the DST was also available for this particular bacteria. So Listeria monocytogenes is one of the important pathogens for community-acquired bacterial meningitis in adults. It has a high case fatality rate of close to 15 to 25%. The diagnosis has to be considered in all older or chronically ill adults with aseptic meningitis. In our patient, there was definitely hypoglycemia, which was also observed. The presentation is subacute with illness developing over several days, and it's not usually an acute onset presentation like we see in case of Streptococcus pneumoniae. And nuchal rigidity, meningeal signs are less common. Photophobia is also infrequent. Patient, however, can have severe rhomboencephalitis, so brainstem involvement and lesions in the brainstem can be one of the clues towards Listeria meningoencephalitis. 1 to 10% of the cases with CNS infection can result in macroscopic abscesses, which is predominantly because of the bacteremic seeding, and the CSF count can vary between 100 to 5,000. It's rarely very high. So in this patient, the molecular assay definitely was a game changer. It helped in the rapid diagnosis. Similarly, we have the other molecular assays like the BCID panel, which can be performed from the positive blood culture. And this particular panel helps us in the identification of the 24 pathogens, bacterial pathogens, 5 common Candida species, and 3 resistant genes, including the MECA, VAN-A, VAN-B, and as well as the 5 major carbapenemases, which can be detected at the BCID panel. We also have the URTA panel, which includes the multiplex PCR for the common upper respiratory pathogens, and this detects the 17 viruses because most of the URTI is caused by the viruses, which includes the influenza, rhinoviruses, as well as the RSV, and 3 bacteria, which are most likely to cause the URTIs. The sensitivity and specificity is close to 95 and 99% respectively. There is also this panel for the diarrhea, which is the stool for GI multiplex PCR. And this is again helpful in the diagnosis of bacteria, viruses, as well as the parasites, which are responsible for the diarrheal diseases. We have a GI panel, which is a joint infection panel, and I'm going to discuss this subsequently in this particular with the help of this case. So this is a this is a case where we had used the GI panel, and it's important to understand that how it had the impact in the treatment of this lady. This is a 73-year-old lady who had undergone bilateral TKR almost a year back for osteoarthritis. Then she presented with severe uh, left-sided hip pain, which was associated with fever. So there was fever with left-sided pain, and then the fever increased to 105 in the next 2 days. She got admitted. There was leukocytosis. There was significant increase in the biomarkers, which was ESR was 70, CRP was close to 400, the PCT was also elevated, indicating that there is a very fulminant disease or infection which is brewing up. So as a part of workup, the serologies were also performed. The IgG was positive for dengue, IgM was negative though. The ultrasound which was done elsewhere showed that she has got multiple calculi in the gallbladder and there is some edematous wall thickening. However, the LFT was not significantly elevated. Besides, clinically, she did not have any abdominal pain. Now, once she was, on admission, the antibiotic Ceftum and amikacin was started by some other team. As there was no improvement and she had this persistent fever, new onset breathlessness, and oxygen requirement was also happening, and she was being shifted to the ICU. The infectious diseases consultation was sought. When we reviewed the cultures which were sent from the emergency, they were no growth. So what we did was um, we we inquired the entire history, and when we inquired the history, there was this clue which was obtained that she said that I have been going and visiting the dermatologist for the severe itching which is happening in my body. And we also sent the repeat blood cultures, and the CT scan was performed, which showed that there was consolidation in the lung. Now, with this, what do you think is the likely possibility? Well, it's Klebsiella pneumoniae, Pseudomonas aeruginosa, Salmonella, typhi, paratyphi, Staphylococcus aureus, Pulmonary pseudocoli. So these are the various differentials we will think over. But in this patient who is presenting with a community acquired infection with an acute onset, and here as we can see that there was intense itching which was mentioned by her. So probably the portal of entry is through the skin and then it is going into the bloodstream, which is then having hematogenous seeding into the lungs. So this was favoring more probably a gram-positive infection rather than a gram-negative, because they were for gram-negative, the patient did not have any intra-abdominal symptoms, neither UTI-related symptoms. So gram-negative infection was less likely here. It was more likely going towards gram-positive bacterial etiology, and very likely Staph aureus was considered, MSSA or MRSA. So we repeated the blood cultures again from the inpatient non-ICU. She was in the ward at that time. We were requested for the blood cultures, at least two sets, which will include one set from the right hand and the other set from the left hand. And we modified this patient to the antibiotics were modified. At this point, we started her on flucloxacillin and clindamycin, and also MRI spine was ordered as she was having backache. The blood cultures subsequently, which was sent from the ward, the initial blood cultures from the emergency were negative, but the blood cultures from the ward, they were positive for the gram-positive cocci. And all the four blood culture bottles grew MRSA. As we can see, oxacillin is resistant and teicoplanin was sensitive with a MIC of 0.5. Now with this, the patient was as the patient was on clindamycin, but the flucloxacillin was discontinued and teicoplanin was initiated at a dose of 12 milligrams per kg. The patient had a resolution of fever, clinical improvement, shifted from the ICU to the wards, and however, in the ward, the patient had progressive leukocytosis and it went up till 39,000, and the CRP was not reducing the way it should have been. So the repeat blood cultures were also done, which were negative. Over the next 6 days or so, the teicoplanin resulted in anemia, hence it was discontinued and the patient was switched to daptomycin and clindamycin. However, at this point also, as there was this persistent leukocytosis, the ortho team insisted that we must add a gram-negative coverage, and that's why cefoperazone sulbactam was added. Even on this, when the WBC count was not improving, we insisted that there is a strong probability of hematogenous seeding of the prosthetic joint. So although the orthopedic team was thinking that this is not going to be infection of the joint, as the patient did not have much symptoms around the knee joint. Still, when there is, as a clinician, we must remember that here the bacteria is MRSA and we are giving appropriate antibiotic. If despite the appropriate antibiotic there is an increase in the count or the clinical resolution of symptoms is not um, as expected, then we must look out for the source control. And as we know, Staph aureus is has the potential to seed into the lungs, into the vegetations, into the heart with vegetations, as well as in a patient who has got implants, it will go and seed into the joint. Hence, the MRI contrast was performed, and that revealed that there was this bilateral fluid collection with subcutaneous hyperintensities was seen. However, still the radiology was not very conclusive. They said that this could be post-operative as well. So we had to do a WBC scan, which revealed that there was this increased uptake around the knee joint, and that was definitely suggestive of infection. So at this point, we went ahead with the IR guided aspiration, and this was sent for the Biofy joint infection panel. The aspiration was turbid, so clinically also there was strong evidence of infection, and the GI panel revealed or detected the Staphylococcus aureus. This was the first case where we had used the joint infection panel in the whole Delhi NCR region, and the resistance gene MEC-A and MREJ were detected. So this was an MRSA, which is correlating with the blood cultures. The blood cultures is positive, as well as the knee joint aspirate is also MRSA. Now, the clinical impact of this detection was that the patient underwent an urgent surgery the next day itself, and the cultures were sent, which turned out to be also positive for the MRSA. However, of course, as the cultures take time, the results were available 2 days later only. The surgery by the orthopedic team was excellent. Excellent debridement was performed. The implant was retained, so they didn't really have to remove the implant. And subsequently, the patient received antibiotics for close to 6 months. So the it's because we could aspirate and then we could send it for the GI panel as well. The detection was earlier and appropriate surgery and treatment could be given. So this we had presented in SITSCON in 2024, the role of novel diagnostics as well as the treatment options in difficult to treat bone and joint infections, and subsequently had published this in one of the journals of clinical research. This was the role of multiplex PCR in identification of a complicated community-acquired MRSA bacteremia, which had led to late onset prosthetic joint infection. Now, this patient by 2023 was doing fine, and in fact, she was planning to visit UK as well. Now, let's take another example where the joint infection panel had a clinical impact. This was a 48-year-old gentleman. He was a diabetic. He had a road traffic accident. It was a left patellar fracture, and then subsequently he had a surgery performed for the same. However, a few weeks after performing the surgery, there was a purulent discharge, and for this, he underwent a repeat debridement and received multiple antibiotics. However, the infection was still persistent. Subsequently, a month later, he underwent another surgery. The wires as well as the foreign body, they were all removed, but the cultures were not sent. Received antibiotics of amikacin for 2 weeks, not much of improvement somehow. Received clindamycin for 4 weeks, there was not improvement. And currently he was on minocycline and was experiencing severe pain. And that's when the patient was referred to us. Now, I'm also emphasizing on these antibiotics. Why? Because as clinicians, we must try to identify the pathogens which are not being covered up by the antibiotics which has been received by the patient. and this can give us a clue towards a possible etiology. So in this patient, what do you think is likely? Klebsiella, Pseudomonas aeruginosa, Acinetobacter, Staphylococcus aureus, don't know. Okay, so let's take it step by step. As this is a patient who has undergone surgery, there is a possibility of Pseudomonas aeruginosa, Acinetobacter, Acromobacter, even Klebsiella pneumoniae. Now, as he's received amikacin, ideally there should have been response to amikacin, but this was not much of response. Again, these two are the pathogens which are likely. This patient had received clindamycin. Clindamycin, if it is not an inducible clindamycin resistant, should have covered the Staphylococcus aureus. And he was also on minocycline. So minocycline will also cover Staph aureus. Since the patient was having symptoms, we thought that there is a strong possibility that it is a bacteria which is not being covered by minocycline. And that is the Pseudomonas, Proteus, Providentia, which are not covered by the tetracyclines. So this is a table which briefly summarizes the various possible organisms which are possible when a particular antibiotic is being given, as these antibiotics lack activity against these organisms. So there is a gap in the spectrum of activity. So we analyzed and thought that yes, there is first possibility of Pseudomonas, Acinetobacter, Klebsiella, E. coli, and then MRSA, maybe. So hence, to prove it, an IR-guided aspiration of the collection was advised, and which along with that, the gram stain and aerobic culture was also advised, and we started this patient on meropenem, 1 gram 8 hourly. Now, luckily for us, the Biophy JI panel was positive and it detected the Pseudomonas aeruginosa. There were no resistance genes which were identified, which means that this is a susceptible Pseudomonas. When the cultures were obtained, the tissue fluid also grew Pseudomonas aeruginosa, and this was susceptible to ceftazidime, also to ciprofloxacin. So combining all the lab results, which includes the PCR as well as the culture results, the clinical impact was that we discontinued meropenem and started this patient only on ciprofloxacin, which is definitely a very cost-effective antibiotic as compared to the IV medications. So it saves the cost of the patient if susceptible. So it's important to remember that when we have the uh, joint infection panel, sometimes the joint infection panel may not be able to detect certain bacteria like the Coagulase negative Staphylococcus aureus, Acromobacter, NTM, Burkholderia pseudomoli, as well as Aspergillus species. These are the certain pathogens which may not be identified, as well as Acinetobacter. It is a good platform for diagnosis of infections like Pseudomonas, Staph aureus, Enterobacteriaceae, including the spikes organisms like the Serratia as well as the Enterobacter, E. coli, Klebsiella, the Enterobacteriaceae. Now let's move on to another syndrome, which is a patient who had presented with diarrhea, and as we can see here, this was the stool which she was passing. So this is a 65-year-old lady who was hypothyroid. She had high-grade fever for 6 days, had multiple episodes of loose stools along with bleeding per rectum, which is indicative that this is kind of a large bowel diarrhea. On inquiring, she was receiving this Herba Life twice daily, and she had received ceftriaxone, metronidazole, cefoperazone, sulbactam. Still, the symptoms were not relieved, and that's when she was admitted under the GI team. Underwent colonoscopy. There were colonic ulcers, as we can see. The endotherapy was also performed. The biopsy was taken, and which was positive for the CMV IHC. The stool cultures were all negative, so there was nothing in the stool cultures. And with this result, they were thinking that probably ganciclovir as well as tigecycline could be started for the patient, and that's when they called us for the infectious diseases opinion. So for in front of us, the main question was what is the likely etiology and which antibiotic should we start? So as clinicians, it's important to remember that when a patient presents with acute diarrhea, we have to differentiate whether it's a small bowel diarrhea or it's a large bowel diarrhea. Small bowel diarrhea will be usually non-inflammatory. It's a non-inflammatory diarrhea with large volume of stools without blood, mucus, and tenesmus. And usually, this is caused by the Vibrio cholerae, enterotoxigenic E. coli, Bacillus cereus, Staph aureus, bacteria like Aeromonas, Plesiomonas, Shigelloids, Rotavirus, and the parasites like the Giardia, Cryptospora, Cyclospora, and Macrosporidia. Whereas the large bowel diarrhea is inflammatory diarrhea, which is associated with dysentery, a lot of inflammation, and there can be presence of blood, mucus, tenesmus caused by Shigella, Salmonella, Campylobacter jejuni, enterohemorrhagic E. coli, enteroinvasive E. coli, Yersinia enterocolitica, as well as Aeromonas, Hydrophilia, Vibrio parahemolyticus, C. difficile, and Entamoeba histolytica. The Salmonella species is usually the non-typhoidal Salmonella, resulting in the large bowel diarrhea. Now, there is also sometimes penetrating distal small bowel involvement in case of enteric fever with Salmonella typhi and Yersinia enterocolitica as well. So now this is a patient who is having large bowel diarrhea. So the possibilities were Shigella, Salmonella, Campylobacter jejuni, and we thought that since she has not received tetracyclines which could work against these pathogens, so we started her on, we thought of starting her on doxycycline, but before that, to confirm, we requested for the GI panel, that is the gastrointestinal multiplex PCR panel. And then once the sample was sent, the patient was initiated on doxycycline. And the Biofire Comprehensive GI panel detected the bacteria Salmonella as well as the Vibrio. The patient responded very well to the doxycycline. There was no tigecycline which was added and no ganciclovir was added as well. So that saved a significant cost to the patient. Another patient who had diarrhea for almost 1.5 months. Now, this patient had an accident. He's a musician and he had an accident while shooting. He had a near drowning experience. During this, he accidentally also consumed contaminated water by mistake. And subsequently, he started having abdominal cramps along with diarrhea for almost 1.5 months. It was a small bowel type of diarrhea. Despite taking the multiple antibiotics, it was not improving, and that's when he consulted us. So when we inquired, this patient was not febrile. It was a lot of abdominal cramps as well as multiple episodes of loose motions. So we suspected that it could be a parasitic infestation rather than a typical bacterial etiology. Viruses are anyways not likely in this patient. So this history becomes also very important in identifying the likely etiology, as with consumption of contaminated water, the parasitic infestations are also likely. However, when we performed the Biofire GI panel, there was a pathogen which was detected, and I could not have imagined this. This was Cyclospora cathinensis, which was detected. So this was only possible because the GI panel detected it, and of course later on our expert microbiologist Dr. Neha Lal also identified it, and these were the AFV positive oocyst of Cyclospora which are seen here. I have also described the importance of identifying the diarrhea early we should never ignore the loose motions. Early diagnosis saves life. And in fact, I have a personal experience with my son as well, where he was having loose motions. I initially started him on Taximo, there was no response. The next day I put him on doxycycline, no response. And then he says that, Mama, I'm still having loose motions almost 8 times a day. And now when I looked back, we had gone to Prayagraj and he had bathed also in the Ganga. So there was a possibility that he probably had consumed the water. And since he had a little GERD, his gut defense mechanism was not up to the mark and he acquired the infection. So I had performed the GI panel and that detected Cryptosporidia. Now, this is one of the first cases in my career as well where a immunocompetent individual is having diarrhea, a Cryptosporidia diarrhea. So which was and we could identify it only because of the GI panel. Of course, subsequently we also requested our microbiologist to she identified even on the stool test, the AFB stain was looked for, and the next day morning, the stool for Cryptosporidia for the modified AFB stain was positive. Another very close relative of mine who had presented with fever, acute diarrhea, septic shock with liver function test abnormality, he uh, when we carefully listened to him, he did mention that before the onset of the fever as well as the loose motions, he had eaten chocolate fudge, which was transported from Bangalore to Banaras. Chocolate fudge has eggs, and that could be contaminated with the non-typhoidal salmonella. So this particular history gave us the clue, and this was confirmed with the stool for biofide GI panel. It detected salmonella species, and the patient was managed then accordingly. This I've described in my another video, which is the diarrhea, as well as another video, which is the fever, diarrhea, and sepsis, and the importance of the blood cultures as well as the PCR in the ICU. So the take-home message is that syndromic infectious diseases approach is very helpful. We must always identify with the help of clinical history and examination what is the site of infection. Molecular diagnostics assays can be the game changers in the ID. They help in the rapid detection of the multiple targeted pathogens and also help us in identifying the resistant mechanism and choosing our antibiotics. This can help us in avoiding the various toxic agents, reduce the healthcare cost, stewardship practices, and also in the infection control measures. So infectious diseases is magical. And with the right identification of the pathogen, we can make early diagnosis, and with the appropriate treatment, it can help in completely reversing the patient's outcome. The patient can have a very good successful outcome, overcome infections, and lead a healthy first life. Thank you so much.